Assalamu alaikum to my lovely nurses. I hope you are fine and your family is good. So today I will explain you about stroke. Once patient is come in the emergency, which signs symptoms you have to observe and make the diagnosis about stroke. So patient came in the emergency. Patient first of all suddenly complained the one side facial drooping, either is right or left, and the one-sided weakness of the extremity, the one side weakness, and the one sided arm drift you will have to see. So when these three symptoms you will say this is the main symptoms, so your diagnosis is patient has stroke. So what you will do once patient came with the diagnosis of stroke, first of all the main you have to do CT scan of the head, that is very important. Then after that standardized stroke assessment we have to do. So why we are doing CT scan or the MRI of the brain? To assess the type of the stroke, is either this is hemorrhagic or ischemic, and the location of the stroke, which side of the brain the patient have stroke. And then we are using standardized stroke assessment. Why we are doing? Because this assessment determines the likelihood of location and severity of an acute stroke. Based on the score from the client, this standardized stroke assessment, the healthcare provider can better predict the expected outcome for the client. So this is very important to do the standardized stroke assessment. And then once the CT scan done, the patient diagnosis confirmed patient have stroke. So what you have to do as a nurse? So we have to do obtain 12 lead ECG. That is very important. Why we will do 12 lead ECG? To detect arrhythmias that could have potentially caused the stroke. For example, the mostly atrial fibrillation. Atrial fibrillation actually increase the risk of the thrombus formation in the left atrium to weak atrial contractility. So once thrombus will come in the thrombus formation in the left atrium, what will happen? The weak atrial contractility, the thrombus can immobilize to the brain. It can transfer to the brain, causing ischemic stroke. So client with atrial fibrillation may require long-term anticoagulation therapy. For example, you can give rivaroxaban. So it's anticoagulation therapy. If the patient have ischemic stroke, the atrial fibrillation, clients with atrial fibrillation may require long-term anticoagulation therapy. Then we have to implement the fall risk precautions because patient have muscles weakness, so we have to implement fall risk precautions, and we have to perform frequent neurological assessments, because ischemia of the brain causing the swelling, the edema and high intracranial pressure, so we have to do frequent neurological assessment. Then the most important, ensuring the tissue plasminogen activator, that we are telling TPA, is available, because thrombolytic therapy is used to dissolve blood clots. So patient have strokes, there is a thrombus, so is used to this TPA we are using to dissolve blood clots and restore perfusion of the brain in clients with an ischemic stroke. So this is contraindicated if patient have active bleeding, uncontrolled hypertension and aneurysm. If these things patient have, the TPA we are not giving to the patient. Then we are applying the CSDs. CSDs mean the sequential compression devices to the bilateral lower extremities. Why we are applying to? Because clients with impaired mobility, the stroke, can develop venous thromboembolism. So usually anticoagulant prophylaxis, for example, the heparin is used. But when the client receive TPA, if you give TPA to the patient, never give heparin to the patients. Hold for the 24 hours, 24 to 48 hours. Why we will hold? To reduce the bleeding risk. So therefore prophylaxis SCDs is recommended at all the times. All the times apply the SCDs is very important. And the heparin we are mostly using for the anticoagulation therapy, mostly we are using. So once you are using heparin, if you give the TPA already to the patient, so hold heparin for 24 to 48 hours. Why? To reduce the risk of bleeding. So for the stroke, we are using the TPA. So I will talk about which conditions we are not giving the TPA. That is very important. So TPA is tissue plasminogen activator. We are mostly giving to the stroke patients, but there is some indications and the contraindications. So we will talk about the contraindications. The TPA mostly we are giving to the patients of myocardial infarctions, ischemic stroke, and the pulmonary thromboembolisms. So thrombolytics actually is excellent to dissolving the clots. Some clients may develop life-threatening bleeding as a complications. So therefore, before giving the TPA, the nurse should assess for the following exclusion criteria to ensure the client has no serious risk of hemorrhage. So what you should have to do before giving the TPA to the patient, ask the client caretaker about history of recent surgery or trauma. If patient have recent surgery or any trauma within 2 weeks, major surgery is an exclusion, mean we cannot give thrombolytics therapy because TPA dissolve all clots in the body and may therefore disrupt the surgical site and cause bleeding. So if patient have recent surgery and within 2 weeks or any trauma within 2 weeks, never give TPA to the patients because the TPA will dissolve all the clots. So this is not good for the patient. And then we have to maintain blood pressure. If the less than 185 to 110, if patient blood pressure is more than 185 systolic and 110 diastolic, is an exclusion. We will not give TPA to the patient due to the risk of intracerebral hemorrhage. So if the patient blood pressure is more than 185 by 110, never give TPA to the patients. Then review the client current home medication list. Why we will see, because this review we will perform to assess any additional anticoagulation. If the patient is taking any anticoagulation therapy, this is also exclusion. Number 4, verify the exact time of the stroke symptom started. Is very important because the TPA is very sensitive and must be administered within 3 to 4.5 hours from onset of the symptoms. For example, the patient come in the emergency within 3 to 4.5 hours, then you can give TPA. But if he come after 4.5 hours, this is exclusion. Never give TPA to the patient. And during the TPA, once this TPA started already, during the TPA administration, the nurse should closely monitor the client for signs and symptoms of intracranial hemorrhage because it's a life-threatening complication of thrombolytic therapy. So what sign and symptoms you will observe? You will notice the patient have intracranial hemorrhage, decreased level of consciousness, client may be disorientated, agitation and confusion, patient have maybe forceful projectile vomiting, and severe hypertension. The blood pressure is systolic more than 180 and diastolic more than 120. So in this condition, if the patient have intracranial hemorrhage suspected, we will repeat the CT scan of the head. Is the priority action to identify the bleeding. So once intracranial hemorrhage confirmed, what treatment we have to do? Reverse anticoagulation. We will give tranexamic acid for the reversal, and blood pressure management. We will give calcium channel blocker like nicardipine, and maybe surgery is required to prevent life-threatening complications. So keep in your mind the intracranial hemorrhage is the bleeding that is inside of the skull. This is life-threatening situation. So without prompt treatment, if we will not reverse, the patient death can be happen. I hope you like the lecture. If you like, please share, subscribe my YouTube channel, and don't forget to push the icon bell button so you can receive my coming videos lecture. Thank you very much. Take care of yourself. Allah Hafiz.